Have you ever felt anxious after receiving medical care, uncertain of what the final total would come out to? You're not alone. The reality is that healthcare in the US can be a confusing and often head scratching field to navigate. While it's not something we enjoy, it is a task that most of us have experienced before. In 2021, health spending in the US increased to $4.3 trillion, according to the Centers for Medicare and Medicaid Services. One expert that's ringing the alarm on these out of control prices is Dr. Ricardo Nuila, an associate professor of medicine at Baylor College of Medicine and author of The People's Hospital, Hope and Peril in American Medicine. With health spending being as high as it is, he argues a more accurate term for healthcare would be medicine incorporated.
Well, I think that the medical experience today is just one where the first thing that comes to mind is how much are they going to bill me for it? And that's why I think that the healthcare system is best described as Medicine Inc., because you can see how everything is orchestrated in such a way as to extract as much money from your insurance or from your pocket as possible. And that's not, I'm sorry to sound naive and whatnot, but that's not what I envision as medicine.
Nuila believes that patients should be the focus of healthcare instead of seeing each person who walks through the door as a checkbook. Due to his career at Ben Taub Hospital in Texas, Nuila believes the public healthcare system offers this patient experience more than private institutions. Ben Taub is considered a safety net hospital, which means it provides complete care to anyone who needs it, particularly people who can't afford quality health insurance.
A lot of the first safety net hospitals have arisen from public hospitals, but as reimbursement models, like for instance, Medicaid. Medicaid is an insurance that's a union of the state and the federal government to try to help people who don't earn enough to afford health insurance. Medicaid reimburses doctors and hospitals at a lower rate. And so some hospitals and doctors just don't take Medicaid, and that creates an enormous gap, right? Safety net hospitals have tried to fill that gap to say, we want to just provide coverage for people.
Safety net hospitals are notoriously hard to fit into one definition. Public hospitals like Ben Taub may be an example most people think of, but both nonprofit and for-profit institutions can also fit under the umbrella definition.
I think that the collective identity is we are addressing the needs of people who can't get service from the larger healthcare system. And so they've adapted in order to try to address those needs and try to plug patients into clinics, into the healthcare that is not obviously available for them.
What's special about Ben Taub is it's part of a larger system throughout Houston called the Harris Health System. Because of this, doctors are able to refer patients to clinics around the city for specialized treatment that all operate within the same healthcare structure.
I can see the notes that clinic doctors have written on patients. The referrals are to specialists within this system. It's not disconnected the way that a safety net hospital that it's by itself would have to reach out to other entities, and there might not be that cohesion.
The hospital is also connected with Baylor College of Medicine, which means it's staffed by top physicians and medical students. This year, Baylor College of Medicine is ranked 16th in the country for primary care and 22nd for research. Collaborating with a great medical school has helped make Ben Taub successful. But Nuila says the Harris Health System's history is what makes it truly unique from other safety net institutions.
In the early 1960s in Houston, there was only one facility available for people who couldn't afford it, and that was a charity hospital called Jefferson Davis Hospital. Since it was, quote, a charity hospital, the funding for it really came from a couple of sources, the county government and the city government. And they were at odds with each other because they wanted to dump all the payment onto the other entity, right? So there was wars about like how the city was going to cut funding so that the county would take over this charity. Nobody wanted to pay for it.
Which left the institution without enough money to properly care for its patients. Rumors began to spread about the terrible conditions. People whispered about hungry infants crying throughout the night. A novelist decided to volunteer there and wrote a series of opinion pieces that finally exposed the truly awful state the hospital was in.
What occurs from that is that the city takes notice, but not just the city, the country, and internationally, it gains headlines. Houston at the time was this city, it was NASA during the space race, was home to Houston. It had built the Astrodome, so it was viewed as this city of the future. And so now the reputation is, in the headlines, the city of the future can't even take care of its poor, right? So it becomes a civic issue.
This publicity spurred multiple attempts to improve the situation. Finally, a citywide vote decided to fund the institution through property taxes, much like the funding for public school districts. That decision is still upheld today, meaning that as Houston's population grows, so does access to medical care.
As the city has grown, as more property taxes, it becomes a more robust fund. So I think all of those things come together, like the right academians, the right vision for what healthcare can be for people who can't afford it, the growth of the city, but also that history, all of that coming together have made it very successful.
Unfortunately, the Harris health system is an outlier. Nuila notes America's healthcare system has never been fully functional, partly because it's always been tied to your job, leaving many people uninsured. Since the first employer sponsored healthcare plan in 1929, a main barrier in accessing medical care has been insurance.
People who did not have insurance, many from vulnerable populations, if they would go to the emergency room, those emergency rooms would end up dumping patients onto the public hospitals. And there were cases where people would die in such a situation. And so this prompted in the 80s that legislators had to put a patch on it, and that patch was EMTALA, Emergency Medical Treatment and Labor Act, which is to say we need to protect the rights of people who might be transferred in emergency conditions and might die.
Meaning that emergency rooms now had an obligation to give all patients stabilizing care, regardless of insurance status. EMTALA helped get patients through these doors, but the law didn't specify the quality of care required. A patient's emergency may be due to a chronic illness, but as long as the hospital staff manages the current symptoms, they don't have any obligation to treat the chronic issue that will inevitably bring the patient back to the ER. Nuila says this revolving door continues on because there's no financial incentive for private hospitals to change.
Because it was patchwork, it also didn't detail how providers would get payment for this. So from the perspective of emergency doctors or doctors in emergency rooms, it's like, okay, there's this law, and now we have to provide stabilizing treatment for everybody, but there's a whole segment of population who has this, who doesn't have insurance, and so hospitals wouldn't get reimbursed, physicians wouldn't get reimbursed, and so that has really shaped the way that emergency rooms and hospitals have looked at providing care for the uninsured over the last 30 years.
But public healthcare systems operate differently.
One of the fundamental reasons that it's cheaper is because it's directly providing the services itself. It's not going through an intermediary.
Safety net hospitals often lean on Medicare and Medicaid to pay their bills, as well as other government funds. The Harris health system is structured in a way that they don't have to go through a third party in order to provide care, which Nuila says really lowers the patient's out-of-pocket cost.
Some people estimate by it's a fourth to a half the price per year per patient as compared to what Medicare or private insurance pays. So it's quite a huge change in the cost of medical care.
While Ben Taub is designed to care for the most vulnerable people in the city, both financially and physically, the hospital's also world-renowned for its top-level care.
It has facilities that other hospitals can't afford to upkeep, like, for instance, burn units, or, like I said, trauma centers, which are other hospitals, even private hospitals, find it very difficult to keep those facilities open. So that's one level of vulnerable that it takes care of. People who are burned or people who are in trauma can find access there. And the other is the financially vulnerable. So the people who cannot afford health insurance. Almost 45% of the patients who are seen have no insurance whatsoever. And so it's just common for us to deal with patients who are uninsured.
A public system like Harris Health is a rare find in the U.S. On top of its university connections and the system's historical precedents, Nuila believes that Harris's dedication to prioritize public health over profit is the big difference.
I don't want to make it sound like every single hospital in America, but in general, the hospitals where patients visit, they're aware of the expense of healthcare, but they're also aware of the basic fundamental rule of healthcare in America is fee for service, meaning that the more that you consume of healthcare, the more you'll be charged. That is what President Nixon referred to as the illogical incentive in our healthcare system.
And though there's been attempts to change the system, the pay-to-play structure continues to be a foundational part of healthcare.
Hospitals understand often that the more tests you do or the more that occurs in the hospital, the larger the bill, the more that they can extract from patients. We have to remember that healthcare is the biggest business in this country. 19 cents of every dollar spent in the United States goes to healthcare. That is double of what it is in other Western European countries. we're not talking about just a little bit more we're talking about an enormous, enormous industry.
Instead of patchwork laws that are full of loopholes, Nuila believes the best option is to rethink the entire system itself and move away from for-profit healthcare. It's a daunting task, but with the continuously rising cost of care, it may be necessary. Nuila's book, The People's Hospital, is available now wherever books are sold. You can find more about Dr. Ricardo Nuila and all of our guests on our website, radiohealthjournal.org. Our writer-producer is Kristen Farah. Our executive producer is Amira Zaveri. I'm Elizabeth Westfield. Coming up next week on Radio Health Journal.
It appears somewhat more likely than the general population, but it's not the majority of causes. And if we just look for mental illness, we'll miss the majority of mass violence.
Is mental illness a scapegoat for mass violence?
Then why one expert says sugar has much better uses than sweetening our food.
Much in the same way that I look at oil as too valuable to burn, I look at sugar as far too valuable to eat all of it.
All that and more on Radio Health Journal.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
It's really clear from long-term bird banding records that the timing of bird migration is changing. Spring migration is getting earlier and earlier over time.
The changing patterns of bird migration. Then,
I had only acted up until that point of getting my first apartment and emancipated at 14, and I didn't have a domestic skill to save my life.
We speak to the one and only Drew Barrymore. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
And that's Radio Health Journal for this week. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.